anal canal and we do not leave a rectal cuff. Yes, I agree with you, Professor.
Thank you.
Professor Ahmed, when you start a new adjuvant chemoradiation before the rectal surgery, what is the proper time for surgery at that time?
What we used to do is we used to wait for 4 to 6 weeks after completion of neoadjuvant radiochemotherapy. But now it's the time is moving for 6 to 8 weeks, and that's why now I usually do the surgery at 6 weeks. So it's midway between the 4 to 6 weeks and 6 to 8 weeks.
Do you prefer the short dose of radiotherapy? Short dose of radiotherapy for 5 days at the start on day 7?
We never did it.
Combined chemo and radio?
No, we never did this because of higher toxicity. And we have our patients. Of course, this can be applied for certain circumstances. For example, a foreign patient coming to you, and of course the tumor should be small because this short course does not decrease the size of the tumor, but it decreases the incidence of local recurrence. Yes. And of course, all of our tumors, we are all aware that are usually very big tumors that will not be helped by this short course.
Yes. Thank you.
Dr. Ahmed, please, I want to ask, as the free mesorectum is very important, and when it is infiltrated, it is associated with local recurrence in many cases. It differs if the infiltration is anterior or posterior or lateral, or it is the same. So we have, as a pathologist, to define the site of infiltration, anterior, posterior, or does it matter for you?
Well, actually, it doesn't matter. Anterior or posterior is a confounding factor because anteriorly the mesorectum is very thin. So it is probable that when there is anterior infiltration, we will not achieve a good circumferential margin. But actually, what is important is the circumferential margin. Even if it is posterior and it is very big tumor and invading the circumferential margin, it will be worse from an anterior tumor not invading the circumferential margin. So this is what we always ask the pathologist, and if there are some pathologists here, I know that we do not always do this as a routine, but we have a multidisciplinary team meeting regular in our unit in Ain Shams, and with us is an eminent pathologist, and we took time to teach pathologists what we need, and also she taught us what she needs from us, how to send the specimen and how to write the report. And again, I'm emphasizing the role of the multidisciplinary team is very important.
Okay.
What's your opinion about covering ileostomy?
Covering ileostomy in lower rectal cancer, and also the most recent, as you have said now, the tumor-specific mesorectal excision in the upper third of the rectum. You cut through the lower part of the mesorectum. Also, is it would you think that it is difficult to identify the lower border of the tumor and to measure to cut in a distance to be safe, to leave safety margin, good safety margin, and also the anastomosis may be a little bit difficult with the presence of mesorectum more than if you will remove the mesorectum totally. Would you agree with me?
Okay, these are 4 questions.
Yes.
So I will start, if the chairman allow me, answer the 4 questions. So regarding the covering ileostomy, it's not a routine, but as a general rule, if the patient, as you go lower in the pelvis, so if the anastomosis is lower, and if the patient is taking, took, for example, neoadjuvant radiotherapy, then we are more with doing ileostomy. But it's not the routine. It depends on the local condition. Regarding the feeling of the tumor and how do you feel it? Of course, you have to feel the tumor and feel a good distal safety margin. If you do not feel it, then you can go with a scope intraoperative to locate the site of the tumor. Yes. But important warning here is that sometimes we get patients referred after taking neoadjuvant radiochemotherapy, and these are very difficult patients. Sometimes the tumor disappears completely and you cannot really identify it. Yes. So my advice is for anybody is to locate the tumor before starting the neoadjuvant radiochemotherapy and writing this on the file of the tumor. That is, the tumor is, for example, 10 centimeters or whatever from the anal verge, and we are going to do low anterior resection, for example. And sometimes in writing the files, we are going to do APR even if the tumor completely disappears. So this is very important to assess the tumor before neoadjuvant.
Yes.
And the third question is regarding
The anastomosis may be difficult also with the presence of part of the mesorectum. Is it?
if of course you have to defatten. We all know
Yes.
this. If you are going to do an anastomosis, you have to defatten, remove the fat.
Yeah.
But if you go low, high up anastomosis is not difficult. A lower anastomosis, the mesorectum is usually thin.
Yes.
So it's not again very difficult. But the most difficult is when the tumor is very low and the patient receives neoadjuvant radiochemotherapy and the rectal wall is thick and the stapler is not closing safely. And in those patients, we do a coloanal anastomosis. We abandon the stapler and we go from the anal canal. We open the anal canal. We divide the rectum at the top of the anal canal. And then we do mucosectomy, remove the mucosa of the upper anal canal, and we do a hand-sewn colorectal anastomosis, which is very easy and safe.
Thank you very much. Thank you very much.
Thank you, Professor Ahmed.
Thank you very much.
Thank you.
Now, Professor